Welcome to the Deep Dive. Today we're working with some really detailed physical therapy lecture notes, and they cover the entire spectrum of amputation management and rehab.
That's right. Our mission really is to walk through that whole clinical journey of limb loss. We're not just going to talk about the surgery itself. We want to detail the meticulous multi-phase path that clinicians use to get a patient back to their highest level of function.
And we really have to start with the scale of this because the numbers in the U.S. are just, well, they're staggering. We're talking about 2.3 million people right now living with limb loss.
And it's growing fast. Our sources say it's almost 500,000 new amputations every single year, 465,000.
Wow.
And the vast majority, something like 83%, are in the lower limb, so the leg.
So if you're picturing this as being mostly from, big traumatic events, industrial accidents, combat injuries, that whole picture is basically flipped.
It's completely flipped, yeah.
Yeah.
Trauma only accounts for, maybe 12.9% of cases? The real drivers today are chronic diseases.
Right.
Diabetes is number one at a huge 57.6%. And that's often tied up with vascular disease and infections.
And that shift from an accident to a systemic illness, that just completely changes everything about the care. And for diabetic patients, the outlook it's pretty stark.
It is immensely stark. A patient with diabetes is 30 times more at risk for an amputation.
30 times.
30. And of those who have one, 90% of them already had a foot ulcer that just wouldn't heal. But here's what's maybe the most sobering part.
Okay.
The prognosis for the other limb, the sound limb. 55% of those patients lose their second leg within just 2 to 3 years.
Wow.
It just tells you that the amputation itself is often just a symptom of a much, much bigger health crisis that's not under control.
That progression from the ulcer to the first amputation and then such a high risk for a second, it just screams how important the preventative care that should have come before all of this really is. And we also have to talk about the demographics here because the disparities are pretty shocking.
They are, absolutely. I mean, while almost half of amputees are over 65, you just can't ignore the equity issue.
Yeah.
Individuals who are Black are 4 times more likely to have an amputation than white individuals. And for Latinx individuals, it's 1.5 times more likely. The sources link this directly to socioeconomic factors.
And when you look at the prognosis for patients where the cause is vascular disease, I mean, it's just frightening. A 50% mortality rate within 5 years. That number really makes you see the surgery not as a cure, but often as a last resort in a really long health battle.
And that kind of complexity, it just demands this huge coordinated team effort. The sources really stress this multidisciplinary approach. You need the vascular surgeon, the physiatrist, PT, OT, a prosthetist, a social worker, psychologist.
The whole team.
The whole team. And they need to be involved from the second limb loss is even on the table, which, sounds great, but getting that to work seamlessly is a huge challenge.
Okay, let's dig into the actual surgery, the mechanics of it. And let's start with some key terms because the language here really dictates the entire rehab plan.
For sure. The first one is a simple but really crucial distinction. An amputation is a surgical cut through the bone.
Okay, through the bone.
Right. So the transtibial amputation, what people might call a BKA or below-knee amputation, that goes right through the tibia bone. But a disarticulation is different. That's a transection through a joint.
So like a knee disarticulation separates the joint itself.
Exactly. And then post-op, we call the part that's left the residual limb, and the intact side is the sound limb. Simple but really important terms.
Got it. And the sources also draw a big line between upper extremity UE and lower extremity LE amputations.
Yeah, they're very different worlds. UE amputations are much rarer, maybe 9 to 17% of all cases, and they are almost always from trauma.
Like we were saying before.
Exactly, like 77% are from work accidents, crush injuries, combat. Those patients often have fewer other health problems and can go straight home.
But the LE amputations, that's the other 80 to 90%, they're much more likely to go straight to inpatient rehab because of all those underlying diseases we talked about.
And for LE surgery, the goal is so specialized. It's not just remove the bad tissue. It's about preserving the maximum possible limb length with good soft tissue coverage to create a residual limb that's durable and can actually handle the pressure of a prosthetic.
I found the part about how they handle the nerves during surgery really fascinating. It sounds like they're trying to get ahead of chronic pain before it even starts.
That's precisely the goal. It's meticulous work. So blood vessels are cauterized for circulation, but the nerves, they're pulled with tension, cut cleanly, and then allowed to retract back up into the soft tissue.
So they're not near the surface.
Right. You want to prevent that cut nerve end from getting stuck in scar tissue near the skin because that can turn into something called a neuroma, which is a major source of pain down the road.
And all this prep work leads to how the muscles are actually closed over the bone, which seems to dictate the stability of the whole limb. The sources mentioned two main techniques, myodesis and myoplasty.
Yes, and the choice between them is critical. Myodesis is really the gold standard if the tissue is healthy enough. That's where the surgeon attaches the muscle directly to the bone.
An anchor.
A powerful anchor. Think of the quad muscle being sutured right to the end of the femur in an above-knee amputation. That gives you a super stable limb and much better control over a prosthesis later.
And the other option is myoplasty.
Right. Myoplasty is when they attach muscle to the opposing muscle or fascia. It gives you good soft tissue padding, but it's much less stable. It's more of a compromise when the bone or tissue is in bad shape, maybe from infection, and you just can't get that solid bony anchor.
So the second that surgery is done, the physical therapy pathway really kicks into high gear. The immediate goals are what? Pain? Swelling?
Pain management, edema or swelling control, wound care, and I would argue most critically, positioning.
Positioning. Why is that so important right away?
Because the risk of contractures, where the muscles shorten and get stuck, is incredibly high. And a contracture is a major, major barrier to ever using a prosthesis successfully.
So what are the positions they're fighting against?
Well, gravity and comfort, basically. Patients just naturally want a rest with their joints bent. For an above-knee amputee, the hip wants to flex, abduct, and turn out. For a below knee, it's hip and knee flexion. And that bent knee, that knee flexion contracture is devastating. It can make fitting a prosthesis almost impossible.
So what's the fix? What's the one thing PTs are telling every patient to do?
It's simple, but so powerful. Prone lying on your stomach.
Okay.
We encourage them to do it several times a day. It uses their own. Exactly. They protect, they provide compression, and they start the shaping process. You have soft dressings like ACE wraps, which are flexible, but can sometimes allow that knee to bend.
The thing you're trying to avoid.
Then you have semi-rigid options, but the most proactive are the rigid dressings, like something called an IPOP.
An IPOP. Break that down for us.
It stands for immediate post-operative prosthesis. It's basically a rigid cast or shell they put on right in the operating room. For a below-knee amputee, it's a game changer. It locks the knee in full extension, which completely prevents that flexion contracture we're so worried about.
Now let's shift to a challenge that I think a lot of people have heard of, and that's phantom pain. It's very real.
Oh, it's extremely common. Our sources say 60 to 80% of amputees experience phantom sensations or pain. And it's a purely neurological thing. It's caused by what we call cortical remapping.
So in the brain.
All in the brain. The brain has this map of the body, and when a limb is suddenly gone, that part of the map gets confused. It tries to send or receive signals from a body part that isn't there anymore, and that misinterpretation can be felt as pain.
So you're basically trying to trick the brain's GPS system.
That's a great way to put it, yeah. And a lot of the PT management is non-drug based. We use things like mirror therapy, where the patient looks at the reflection of their intact limb, which can trick the brain into thinking the missing limb is moving without pain. And also desensitization, just gradually touching the residual limb with different textures to calm those nerves down.
So once we're past that acute phase, we move into what's called the pre-prosthetic phase. This is after the wound is healed, but before they get their permanent leg.
Exactly. And the focus here shifts entirely to building functional independence without the prosthesis. The body has to be ready for the huge new demands of walking on an artificial limb. So we're talking transfers, wheelchair skills, and a lot of cardio.
And you said earlier that getting full hip extension is non-negotiable for walking well later on. Why is that one movement so critical?
Because if you can't get your hip fully straight, you're going to develop all these bad habits when you get your prosthesis. You'll arch your back, you'll lean way over to the side. It leads to chronic pain, instability. It's just not an efficient way to walk. Full extension is the foundation for a symmetrical gait.
And what about strength training in this phase? I'm guessing a lot of the heavy lifting is actually done by the intact limb.
It has to be. That sound limb is about to become the sole pillar of support.
Right.
It's going to take 100% of the body weight every time they take a step, so that leg needs to be incredibly strong.
Right.
For the residual limb, we focus more on the specific muscles that will control the prosthesis. The hip extensors, abductors, adductors, the muscles that move the leg back, out to the side, and in.
Which brings us to a really key point. The metabolic cost,
Mm.
the energy it takes just to walk. How much higher is it?
It's just staggering. The sources say that for an above-knee amputee, just walking takes about 60% more energy than for someone with two legs.
60%.
60. Even for a below knee, it's about 25% more. So that's why cardio isn't just a nice to have, it's absolutely essential for them to have any kind of functional endurance.
Okay, so once the wound is fully healed, maybe 8 to 12 weeks out, the focus shifts to really intensely shaping that residual limb.
This is non-negotiable for getting a good prosthetic fit. The patient will use elastic bandages or special socks called shrinkers, and they wear them 23 hours a day.
Wow.
And there's a very specific technique. You have to wrap from the very end of the limb up towards the body in a figure-8 pattern, with the pressure being tightest at the end and getting looser as you go up. This squeezes the fluid out and shapes the limb into that nice cone or cylinder shape that a socket can fit onto.
And what about the scar itself?
Once it's fully closed and healed, we start scar massage. Just gentle pressure up and down, side to side, and in circles to keep the skin from getting stuck down to the tissue underneath. An adhered scar under the pressure of a socket can be incredibly painful.
To measure how ready a patient is and to predict how well they'll eventually walk, the sources talk about a specific tool, the amputee mobility predictor, or AMP-NO-PRO.
The AMP-NO-PRO is essential. It's a test we do before they get a prosthesis, and the score they get helps predict their future potential. We call that their K level, and that K level is what determines the kind of prosthetic knee or foot that insurance will actually pay for.
Okay, let's quickly run through those K levels because they give a really clear picture of what recovery can look like.
Sure, so K0 is the lowest and not really a candidate for a prosthesis, maybe just for transfers. K1 is a limited household ambulator, walking on flat ground at one speed. K2 can handle low-level barriers like curbs. K3 is the goal for most active people. They can walk at different speeds, handle most obstacles, maybe do some light recreation. And K4 is for, high-level athletes, kids, people whose needs go way beyond basic walking. The AMP-NO-PRO score really links all that hard work and therapy to a tangible quality of life outcome.
And you can see how all through this you need that psychological support, resources like the Amputee Coalition, and just constant conversation about the patient's own goals.
Absolutely. Function versus appearance, getting back to work, it all has to be part of the plan.
So after this deep dive, it's so clear that successful recovery is defined less by the surgery itself and much more by all of the rigorous, meticulous planning that happens before and after. Everything from their pre-op conditioning to the diligent limb wrapping and strength training.
That's the key takeaway. Everything in this process is predictive. Preventing a contracture with good positioning, achieving full hip extension, getting a good AMP-NO-PRO score, each step directly predicts the patient's potential and what their functional ceiling will be. The whole journey is just a masterclass in adaptation.
So we talked about how phantom limb pain is basically the brain trying to remap itself after losing a limb. And the sources mentioned things like mirror therapy and even more advanced tech like deep brain stimulation. It makes you wonder, how close are we to being able to proactively remap that sensory cortex to prevent phantom pain from ever even starting, instead of just managing it after the fact? That really feels like the next frontier.
Welcome to the deep dive. Today, we are strapping in for a really deep exploration of a world that is far more demanding and biomechanically sophisticated than most of us ever imagine. Lower limb prosthetics.
It really is.
We're moving way beyond just recognizing a piece of technology. Instead, we're unpacking the intricate clinical decisions, the precise engineering, and the profound human adaptation that's required to make these devices truly work.
And we're basing this all on a detailed clinical overview from Mike Sosi, a certified prosthetist orthotist, which gives us a fantastic roadmap.
It does. So let's start with the big picture, the context, because the scale of this is, well, it's immense.
It is. I mean, if you look at the demographics, and this is older data, from 2008, the total number of amputees in the U.S. was already well over 1.5 million.
Wow.
But here's the really startling part. It's the ratio. You've got about 41,000 major upper limb amputees, but for major lower limb amputees, that number jumps to 623,000.
That is a staggering difference. It just immediately tells you where the bulk of the focus, the engineering, the rehab complexity, where it all resides. It's below the hip.
Exactly. And the source material makes one thing incredibly clear. Amputation rehabilitation is a marathon. It is absolutely not a sprint.
You don't just walk out of the hospital and it's all solved.
Not at all. The challenges for the user, they're not just physical. There's profound emotional acceptance. the huge learning curve to actually trust a mechanical limb,
I can't even imagine that.
and then just mastering basic things, going from sitting to standing, bearing your full weight on this new device, and then trying to understand all the complex features of the components that are literally holding you up.
It demands so much patience. Okay, let's unpack some of that foundational knowledge. Let's start with the experts who actually build these devices, the prosthetists. It's an incredibly high level of training, right?
Oh, the training is intense. It's highly specialized. We're not talking about a weekend certification here. You're looking at a master's degree in prosthetics and orthotics, then a demanding residency, and then it all culminates in board certification and state licensing.
So they're blending mechanical engineering, material science, anatomy.
All of it. It's a massive investment of time and academic rigor.
And even with all that expertise, they're constantly running up against some pretty big logistical barriers.
They are. The two biggest are, without a doubt, cost and coverage.
Let's talk cost first.
Okay, so these devices can easily climb into the tens of thousands of dollars. It just depends on the complexity of the components.
And then the insurance barrier.
Right. And this is what's truly frustrating for everyone. The coverage for certain advanced components, say a really sophisticated foot or knee, varies wildly between different payers, even when the clinical need is, completely undeniable.
So a patient could be a perfect candidate for a component functionally, but their insurance provider just says no.
Precisely. And the last piece is the timeline. This is not a quick fix. The whole process, from that initial healing to the final alignment and gait training, you're measuring it in weeks and often months.
Which has to be a huge source of frustration for someone just wanting to get back on their feet.
It is. It's a constant hurdle.
And because of that complexity, the clinical team, the physical therapist, and the prosthetist, they have to work in lockstep. How do their day-to-day roles differ?
Think of the PT, the physical therapist, as the frontline manager of the residual limb.
Okay.
They're the ones checking skin integrity at every single visit, which is vital. Any skin breakdown can halt all progress. They're also troubleshooting the minor fit issues, teaching the patient how to use prosthetic socks to manage those daily volume changes.
So they're handling the soft tissue interface, the daily mechanics.
Exactly. And reinforcing hygiene and safety. The prosthetist then steps in for the heavier engineering lift. They're the ones doing the major socket modifications, modulating the alignment, so adjusting the angles to fix key deviations, and explaining the really nuanced features of the high-tech components.
Got it. Now let's talk component selection. It seems to be dictated entirely by this metric called functional classification, or K levels. You have to understand this to understand why a patient gets a certain device.
The K level is everything. It's a classification of a patient's realistic potential for walking. And that classification dictates what technology is considered medically necessary and therefore what insurance will actually pay for.
So walk us through that roadmap. What's the scale look like?
It starts at K0. That means no potential for ambulation. So not a candidate for a prosthesis.
Within the NF.
K1 is your limited household ambulator. The goal here is usually short distances, transfers, maybe just stable standing.
And the technology for a K1 is functional, but mechanically pretty simple.
Absolutely. Then you move to K2, the limited community ambulator. This person can handle low-level barriers, curbs, maybe a ramp, but they generally walk at a single, consistent speed, a single cadence.
And K3, this is kind of the gateway level, isn't it?
It is. K3 is the unlimited community ambulator. This is the goal for a lot of patients. They can handle a variable cadence, speeding up to cross the street, slowing down in a crowd, and they can traverse most barriers.
And that's the level that unlocks the really high-tech components.
Usually, yes. The microprocessor knees and feet. Their lifestyle demands that complexity. And finally, you have K4, which is for people who routinely go beyond basic skills, then children, athletes, people with physically demanding jobs. So yeah, that K level is the clinical and financial cornerstone of the entire process.
Okay, let's pivot to the anatomy itself because the terminology here is critical. First, let's clarify the difference between an amputation and a disarticulation.
Right. An amputation is named by the bone that was cut. So below the knee, it's a transtibial amputation. Above the knee, it's transfemoral.
A disarticulation is different.
A disarticulation is a separation right at the joint line. The bone itself wasn't cut through. So you have a hip disarticulation, a knee disarticulation, or at the ankle, which is clinically known as a Symes amputation.
Let's focus on the most distal type first. Partial foot amputations. This covers everything from, say, a toe removal to major procedures like a Chopart. And these smaller devices have this crucial dual mandate.
They absolutely do. The first mandate is protection. The device has to offload sensitive areas, prevent skin breakdown, and prevent or at least slow down deformity of the remaining foot.
And the second mandate is restoration, which is purely about biomechanics. It has to make the foot work like a lever again.
Precisely. To walk smoothly, your body uses three biomechanical rockers. You have the heel rocker at initial contact, then the ankle rocker as your shin moves over your foot, and then the forefoot rocker for push-off.
And if you lose your forefoot, you lose that final push.
You lose the leverage. The center of pressure just stops dead at the end of the residual limb, so the prosthetic has to restore that length, allowing the center of pressure to keep moving forward. It mimics a natural step. Without it, your gait is just choppy and really inefficient.
So these partial foot devices, whether it's a simple toe filler or a more complex AFO-style brace, they're all just trying to restore that critical lever arm.
That's the core goal.
Okay, now let's move up to the most common level, the transtibial or below-knee amputation. The core challenge here seems to be all about managing pressure.
It is. The goal is to maximize comfortable contact while avoiding crushing all the bony areas.
Which makes sense. The tibia is a very sharp, bony structure right under the skin, so how does the socket do that?
Well, there are three main design philosophies. Historically, we had what's called patellar tendon bearing, or PTB.
TTB.
This uses really focal, targeted loading-like, creating little platforms of pressure on areas that can take it, like the patellar tendon itself or the calf muscle. And at the same time, it provides relief over all the delicate bony spots, like the shin bone or the head of the fibula.
That sounds incredibly precise.
It is. Then the field sort of moved towards total surface bearing, or TSB. Think of this like a firm, continuous hug. The pressure is distributed as equally as possible over the entire surface of the limb.
So it avoids those high-pressure spots, and the most common today is a hybrid.
Correct. It's a blend. You get that largely distributed pressure of a TSB, but you still incorporate some targeted loading or relief where you absolutely have to. It really is the best of both worlds.
Now, separating the skin from that hard socket is the interface. You have two main types, a gel liner and a pleat insert. What's the practical difference for the user?
The gel liner is the modern standard. It's silicone or urethane, and you roll it directly onto your skin like a very thick sock. It gives you cushion, it helps shape the limb, and it's key for a lot of suspension systems.
And the pleat insert, it sounds a bit older.
It is. It's a foam insert. It provides great cushion, and its main benefit is that it's highly adjustable. A prosthetist can easily add or thin out the foam in a specific spot. But with this one, the user wears a cotton sock inside the foam insert. It's a different layering system.
Okay, let's talk suspension. This is what actually holds the whole thing on.
And that security is paramount. Pin locking is probably the most common and robust system. The gel liner has a metal pin at the very end that clicks into a lock at the bottom of the socket.
You hear the click, you know it's on.
Exactly. The simplest system is probably anatomical or supercondylar suspension. It just relies on the socket compressing proximally, so it basically hangs on the bony knobs of your femur just above the knee. Simple, but not as secure.
And then you get into suction.
Yes. Pure suction uses a sleeve and a one-way valve to pull air out. It really decreases the motion between the limb and the socket. But the ultimate linkage is elevated vacuum. It uses an active pump that is constantly pulling air out.
That sounds incredibly secure.
It is. It provides exceptional control, but it's also very sensitive to any changes in your limb's volume.
Which brings us to a detail that is critical for every single user, managing sock ply. Why is this such a vital daily task?
This is just, the genius of using simple fabric to tune a rigid, high-tech interface. Prosthetic socks come in different thicknesses, a 2-ply, 3-ply, 5-ply. And you use them because your residual limb volume inevitably shrinks.
It changes throughout the day.
Throughout the day, and definitely over the first 1 to 2 years. The socket that fits perfectly in the morning might be too loose by the afternoon.
And the stakes are high if you get it wrong.
Very high. If the fit gets too loose, the limb pistons up and down and you get painful bony pressure. If it's too tight because you put on too many socks, you can't get the limb all the way in. The socks just take up that extra space to keep the fit perfect.
I heard about a really clever trick using half socks. What's that about?
That's precision tuning with fabric. Imagine your limb has shrunk, so you need a 5-ply sock to fill the space at the bottom. But a full 5-ply sock makes the area behind your knee way too tight.
Right.
So a prosthetist might have you use a half sock, literally a sock cut in half. You put that on first to take up volume just at the distal end without making the top part of the socket uncomfortably tight. It's brilliant, low-tech problem solving.
That is a phenomenal piece of practical knowledge. Okay, last thing for transtibia. Alignment. Why are the angles so important?
Alignment, the position of the foot under the socket, is critical for efficient walking. From the side, the sagittal plane, the goal is to get a smooth rollover, hitting those 3 gait rockers we talked about. And you also have to accommodate any hip flexion contracture the patient might have.
And from the front.
From the front, the coronal plane, the goal is stability. The pylon, that support pipe, should be vertical when you're standing on one leg. It helps you shift your weight naturally. And a quick caution here. Prosthetic feet are designed for a specific shoe heel height. If you switch from sneakers to a boot with a higher heel, you throw the entire alignment off.
Okay, let's move up to the highest level, the transfemoral, or above-knee deep dive. Here the challenge is stability and controlling rotation, because the limb is so much larger.
It's a whole different ballgame. And this is where we see major engineering differences in the socket. The current gold standard is the ischial containment socket.
How is that different from older designs?
Well, the older quad socket just sort of grabbed the limb in a four-sided trough.
Well,
The ischial containment socket is fundamentally different. It provides massive medial lateral stability by transferring weight directly to the pelvis, specifically by cupping or containing the ischial tuberosity.
the ischial tuberosity, that's your sit bone.
Exactly. You're using that hard bony structure, which is designed for weight bearing, as a physical shelf inside the socket to lock the limb in place. It dramatically improves stability. If you don't get that containment, you can't get proper coronal stability. It's that simple.
And with a larger limb, the suspension system has to manage way more force.
It does. Seal-in suction is very popular. A gel liner has a gasket that creates an airtight seal. It's great control, but it only tolerates small volume changes. Skin fit suction is even tighter. The skin itself forms the seal, but it accommodates zero volume change.
And the lanyard system is common here, too.
Yes, the lanyard or pin system. It's reliable, it accommodates volume changes easily, which is a huge plus, and it also allows for a lower build height, which can be more comfortable when sitting.
So now for the biggest component decision at this level, the knee. There are hundreds of types.
And they're all matched to the K level. We classify them by how they control the swing phase and the stance phase. You have everything from simple mechanical knees to knees with hydraulic systems that control speed or weight-activated brakes that prevent buckling.
And then you have the microprocessor knee, the MPK. What's the one thing that sets it apart?
The MPK controls resistance in real time. It adapts. It uses sensors to monitor position and speed and load, which allows for amazing features like stumble recovery. But, and this is the crucial distinction, MPKs control resistance to motion. They do not provide active propulsive power.
So the computer-controlled knee is basically an incredibly smart brake and damper. It's not a motor that pushes you up the stairs.
Exactly. The muscle power still comes 100% from the patient's hip extensors. MPKs are expensive, they need charging, they're heavier, and they aren't always better than a well-tuned mechanical knee.
Which brings us right back to the human element. For a transfemoral user, what actually controls the stability of that knee?
It's all about the body's relationship to the device. From the side, the prosthetist aligns the knee so your weight line falls slightly in front of the knee center. That gives it a natural bias towards staying straight. But if you have weak hip extensors, weak glutes, you can't lock that knee into extension.
And the result of that is
You see that classic anterior trunk, lean, short, choppy steps, and the terrifying risk of the knee just buckling during stance. The stability is driven by the body, not the device.
Then from the front.
From the front, remember the socket is set in adduction. It angles inward. This pretensions your hip abductor muscles, letting the femur brace against the side wall so you don't lurch side to side when you walk.
We should also just acknowledge the extreme challenge for bilateral transfemoral amputees.
The energy cost of walking for them is astronomical. It's exceptionally high. Many bilateral users will start with what are called stubbies.
The stubbies.
They're foreshortened prostheses with no knee units at all. The whole point is to lower the center of mass, to maximize balance and safety, before they even think about progressing toward full-height prostheses.
This has been a true deep dive. We've gone from the logistical hurdles of insurance and K-levels all the way to the biomechanics of a partial foot, the fine-tuning of sock ply in a transtibial socket, and the immense stability challenges at the transfemoral level.
yeah.
It is such a remarkable blend of engineering and meticulous patient care.
It is. And if you connect it all back to the source material, the one consistent theme is that technology, no matter how advanced, is ultimately subordinate to fundamental biomechanics. The device's success is rooted in how well the human body controls it. The constant stress on accommodating a hip flexion contracture or using your own muscles, your hip extensors and abductors, to stabilize these engineered components, it tells a really powerful story.
It really does.
So for you, the curious learner, consider this. Even when you have a microprocessor knee, managing resistance in real time, the most critical control system in the entire operation is still the human body's core strength and alignment. The final precision tuning that determines success is less about the machine's complexity and far, far more about that flawless daily interaction at the delicate interface between flesh and mechanism.